it's my pleasure to introduce Dr. Anderson, whose lecture topic today will be Perspectives on Public Health, Past, Present, and Future. And I can think of no more appropriate lecture title than this for the times in which we're currently living. I would like to briefly review Dr. Anderson's impressive bio, and she was gracious enough to send off what she modestly, I think, deems as the quick bio, and I hope that you'll agree with me that it's fairly impressive. Dr. Cheryl Anderson is professor and dean of the University of California, San Diego, Herbert Wertheim School of Public Health and Human Longevity Science, with a joint appointment in the Department of Medicine, Division of Nephrology and Hypertension. She serves as director of the UC San Diego Center of Excellence in Health Promotion and Equity. Dr. Anderson's research is focused on nutrition and chronic disease prevention with a goal of equitably improving human health, including development of nutrition policy strategies for prevention of cardiovascular disease, chronic kidney disease, and diet-related cancers, promotion of health behavior and elimination of health disparities by personal and environmental factors. Dr. Anderson has served on the Pan American Health Organization's Technical Advisory Group on Cardiovascular Disease Prevention through dietary salt reduction, the National Academy of Medicine's Food and Nutrition Board, and the 2015 U.S. Dietary Guidelines Advisory Committee. She is the chair of the American Heart Association, AHA, Council of Epidemiology and Prevention, and immediate past chair of the AHA's Nutrition Committee. She currently serves on the editorial board of Circulation and Annual Reviews of Nutrition. Dr. Anderson was elected to the U.S. National Academy of Medicine in 2016, so we are very honored and grateful that you could make time for the Emeriti and Retirement Associations today, Dean Anderson. And just as I turn it over to you, I again ask everybody please to mute yourself, and we'll have time for questions and answers after the fact. So please welcome Dr. Cheryl Anderson.
Thank you, Dr. Adler. I am going to share my screen. Well, that one is a different PowerPoint. I just finished teaching, so we need to get out of that PowerPoint, and let me just close it here. And I will find the new one. Okay, let's try this. Okay, this should work. Well, hello, everyone. Thank you so much for the invitation to be with you today. I did a quick glance across the Zoom room and I see faculty from public health. So my apologies in advance. I hope I don't bore you with some basics of public health throughout this. I have such a great deal of respect for those of you in the Emeriti Association who have worked and served this great university and our greater San Diego community, as well as our world, through the work that you've done over the course of your careers. This invitation I accepted pretty much immediately, even though I knew I was going to have a lot going on this afternoon, because we are in a different time than we were in last year, for example, and the ability to meaningfully contribute to a conversation around public health and to share the training, the work, the new efforts that we have on the campus, and how it really ties into a long history that we've been trying to change the public's health here in San Diego through some of the efforts that we have here on the campus. Connecting that all for you this afternoon is really important to me, and I'm just so glad that we have a chance to talk. The images on my title screen here are, of a coronavirus, and then from the 1918 pandemic. And I used to teach this class on I guess I would infection control, where I'd have those images, and students would kind of look at them like, oh, look. And now that is what we all look like when we're walking through general society. And so um, if those of us who don't understand our past are sometimes doomed to repeat it. So here's the outline for today's lecture. I'll talk a bit about some definitions so that we're all on the same page around what public health is, and a little bit about the history of public health, and then come into some contemporary issues in public health, how things have shifted from what we were doing 100 years ago, and how things are still somewhat the same with the lessons that we're learning from pandemic SARS-CoV-2 and resultant COVID-19 disease, and then share with you a little bit on future directions, and most importantly, leave lots of time for questions. So if we start to think about how we define public health, the Institute of Medicine put forward these concepts around public health back in 1988, calling it the science and art of preventing disease, prolonging life, and promoting health, and doing this through some organized community effort, where we're really fulfilling society's interest in assuring that we have conditions in which people can be healthy. Now, that is hugely complementary to what Winslow put forward back in the 20s. Talking about preventing disease, prolonging life, promoting health, doing it through community efforts. Now, in 1988, yes, of course, we were still thinking about sanitation, but it was in a different way than Winslow, talked about sanitation. The environment, right? Now, we, instead of thinking about sanitation of the environment, we're thinking about environmental pollution. We're thinking about climate change in a different look, through a different lens at this point in our history in public health. In 1923, Winslow's definition included the control of communicable infections. Come back to that in a little bit. The education of people about personal hygiene. If you're looking at my screen, you see all of those things reflected in my Zoom background. And then, of course, wanting to ensure that we're able to screen, have early diagnosis and treatment of diseases, prevention of diseases, and having all of that wrapped into our social machinery, our society, to make sure that every single citizen, regardless of where they live, learn, work, play, pray, can have what in public health we think is a birthright to health and longevity. So what's public health? Well, the long and the short of it is that we're working in human populations, and we want to develop and apply knowledge that promotes health, prevents disease, protects the public from exposures to potential harms, and does this in a way that addresses inequities. And we do it in our local communities. So here in the greater San Diego area, we think about what's important across the great state of California, or wherever one lives. And then, of course, we're thinking about the national context as well as things on the global level. And in the pandemic, you really begin to see this interplay between what's happening globally, right? We saw SARS-CoV-2 begin in Wuhan, China. Then we began to see its movement into and effects in Europe. And then, in our coastal communities here, we started to see its impact. So the national stage was set, and then state by state, we started to see things going on. And then we also know very intimately what's going on in San Diego County. So I want to illustrate the contrast between medical care and public health for you with a poem that's called Fence or Ambulance. And it's important as we think about how we define public health to really know how it differs from medical care. And so this is a poem that was written in 1913 by Joseph Mullins. And I am illustrating it with Legos. A good friend of mine who in his youth was a bit of a Lego maniac, put this Lego board together. And I just love using it. So here's a city, Lego city, with various components that we'll need for the story. Okay, So all of the actors are here. And we'll start on the next slide. So as Mullins tells us in Fence or Ambulance, 'twas a dangerous cliff, as they freely confessed, though to walk near its crest was so pleasant. But over the edge fell a terrible duke, slipped over the edge, and full many a peasant. So the people said something would have to be done, but their projects did not at all tally. Some said put a fence around the edge of the cliff, and others said put an ambulance down in the valley. But the cry for the ambulance carried the day, for it spread through the neighboring city. A fence may be useful or not, it is true, but with each heart came brimful of pity for those who slipped over that dangerous cliff and the dwellers in highway and alley. They gave pounds, they gave pence, not to put up a fence, but to put an ambulance down in the valley. For the cliff is all right if you're careful, they said, and if folks even slip and are dropping, it isn't the slipping that hurts them so much as the shock down below when they're stopping. So day after day, mishaps occurred, and quick forth would the rescuers sally to pick up the victims who fell off the cliff with their ambulance down in the valley. Then an old sage remarked, "It's a marvel to me that people give far more attention to repairing results than to stopping the cause, when they'd much better aim at prevention. Let us stop at its source all this mischief," cried he. "Come, neighbors and friends, let us rally. If the cliff we will fence, we might almost dispense with that ambulance down in the valley." "Oh, he's a fanatic," the others rejoined. "Dispense with the ambulance? Never. He'd dispense with all charities too if he could. No, no, we'll support them forever. Aren't we picking up folks just as fast as they fall? And shall this man dictate to us all? Shall he? Why should people of sense stop to put up a fence when that ambulance works just fine in the valley?" But a sensible few who were practical too wouldn't bear with such nonsense much longer. They believe prevention is better than cure, and their party will soon be the stronger. Encourage them with your purse, voice, and pen, and while other philanthropists dally, they will scorn all pretense and put a stout fence on the cliff that hangs over the valley. Better guide now the young than reclaim them when old, for the voice of true wisdom is calling. To rescue the fallen is good, but it's best to prevent other people from falling. Better close up the source of temptation and crime than deliver from dungeon or galley. Better to put a strong fence around the top of the cliff than to put that ambulance down in the valley. So I'm very much taken by how much Joseph Mullins' words from 1913 still seem to matter. We may not use terms like stout fence anymore, but you can think of many scenarios where we're falling off a proverbial cliff rather than putting in preventive services or building environments that are healthy. So when we think about the history of public health, many of those concepts come to bear, right? How did we get to modern day public health? Well, in early civilizations, if we think about, before 500 BC, we were under the Code of Hammurabi, living into like the Book of Leviticus, thinking about the Roman Empire and community projects and games of skill. And this was how we promoted health, right? We were in a spiritual era of public health. We had lots of infections prominent. And were really thinking that there were environmental causes of disease and didn't know much about the diseases necessarily, but we had a pretty good description of symptomology. And in the 18th and 19th century in public health, we saw industrial growth. We saw more efforts put into workplace safety. We had boards of health developing in large cities. And we had, as we think more in the 19th century, come into a modern era of public health where an American Public Health Association was founded. We started to make connections between community efforts, community actions, such as famous epidemiologist John Snow in his attempt to stop cholera from running rampant, took the handle off the Broad Street pump, removing that water source, and ultimately drawing that connection on a community level versus a person-to-person level. So that's the history of public health, kind of where we've been over the last 20 centuries. And now if we think about contemporary issues in public health, we find that we do things a little bit differently, but some fundamental things have remained the same, and some fundamental concepts about public health still come to bear. So in the 21st century, we have what we think of as a period of health promotion, and that follows the establishment of health departments in some of our major cities, Philadelphia, New York, Baltimore, Boston. We have the Social Security Act passed, the first school of public health established. There's a rush to the beginning for the Johns Hopkins School of Public Health and the Harvard School of Public Health. There's a period of social engineering that happened where Medicare and Medicaid were passed, our seatbelt laws were passed. And in more recent times, we really see a lot of effort and emphasis being put on keeping people healthy. The idea that preventive services matter. We've had some successful attempts at establishing, national healthcare programs before the Affordable Care Act came into being in 2010, and holding ourselves accountable to keeping people healthy through our Healthy People metrics. We're currently up to Healthy People 2020. It started back in Healthy People 2000. And a huge success was putting statewide smoking bans in most public places across 28 states in America. Now, in sum, public health is doing a couple of things at any given time. There are 10 essential services of public health, and they are linked with 3 core functions. And if you really think about where we are right now in the pandemic, you'll see that these functions and services together really matter for leadership in times of public health crisis such as these, right? Do we have a system where people are assured good health, where we have the assessment that this assurance is happening, and where we're developing policies to support those health outcomes? We have research always at the center of the core functions, which is why university settings for public health are so important, and a sense of ability to monitor, diagnose, have educational efforts, really mobilize community partnerships, developing policies and ensuring laws get enforced around those policies, having clear links back to healthcare, and then a competent workforce that can assure that these things get executed well. Core to public health is also a concept of equity. This is an infographic from Robert Wood Johnson Foundation, and it shows the difference between approaching health issues through the possibility of a lens of equality versus one of equity. And in the top part of the infographic, you see what equality how equality would play itself out. So here, everyone gets the same accommodation. However, sometimes we need different accommodations for people with different needs. And you'll see on the bottom half of the infographic where when the accommodation meets the need of the individual, it's more likely to actually get to the desired outcome. Over the 20th century, some of the major accomplishments that we've had in public health include increasing life expectancy, where it went from high 40s to high 70s. We've been very successful with vaccinations for childhood diseases, even though we know that we're struggling a bit with an anti-vaccination sentiment. We've done pretty well with controlling most infectious diseases. Right now, we're struggling with the control of one of the most highly contagious ones in our time. We've made our drinking water safe. We have safer workplaces, and we've recognized tobacco use as a health hazard. And then we've seen quite a bit of decline in heart disease and stroke. We've seen decline in motor vehicle deaths. We've had healthier moms and babies and a real strong effort in family planning. The top 10 global causes of disease have been over the 21st century, for the most part, chronic diseases, heart disease and stroke at the top of this cause of death list globally. And while infections do still matter, we have really seen a lot of success prior to SARS-CoV-2 with infection control and needing to think about some of the things that underlie our chronic conditions. Here we see the rates of the 10 leading causes of death in the US in 2017. And again, much of it being chronic. In San Diego, more locally, you may be familiar with the 3-4-50 concept, where 3 behaviors, being physically inactive, having improper diets, use of tobacco, they result in 4 diseases: cancers, heart disease and stroke, type 2 diabetes, and lung disease, that account for more than 50% of the deaths that occur in our region. So this 3-4-50 concept really has driven the public health approach in our region. When we think about the multiple things that cause chronic diseases, it's important to really emphasize that individual sort of birth and genetic components matter. The beliefs and behavioral choices that people make impact how they express their genetic various conditions. So there's an interaction, there's a gene environment interaction that is happening, and that is influenced by the structures around us that allow us to make choices that will ultimately impact our health. So here, it's very clear why schools of public health or public health efforts in our communities rely so integrally on other parts of our systems. So we see that economics matter here in a time of a pandemic. Everybody can see how when public health isn't working, or when we have a public health crisis, how economics become intimately connected to that situation. You see how our healthcare system is also involved in ensuring good public health, and even something along the lines of water quality, which is controlled at usually a local level through public health efforts, and air pollution, all come together to impact people's overall health status. So in modern days, if you'd asked me to come and give this lecture back in November of 2019, we would have been talking about technology and how technology has quite a bit of promise for helping to advance public health concerns. We would have been talking about migration as a real issue in our public health space. We'd be talking about mental health and the opioid crisis. And we'd be talking about climate change and planetary health and how important it is to think about all of the various threats to our public health infrastructure and to the public's health across the lifespan. And those things are all still happening while we have an additional challenge of being in a pandemic. And I want to just, talk a bit about what are some of the lessons that we're learning about public health from pandemic SARS-CoV-2 and COVID-19 disease. So here is an infographic that shows the spike protein of SARS-CoV-2 and its mechanistic action by binding ACE2 on the surface of a human cell to initiate its entry. The SARS-CoV-2 coronavirus probably moved from bats or pangolins into humans. That's a technically, we refer to that as zoonosis. And in humans, we know that infections occur via aerosols. There's been quite a lot of work being done here at UCSD to establish that as more prominently in how we approach SARS-CoV-2, as well as in smear infections by us being able to pick up through things that we might touch like fomites. We have learned through our surveillance systems around SARS-CoV-2 and COVID-19 that we've experienced wide geographic heterogeneity in COVID-19 mortality across the US. And this started very early. In March of this year, we could see that, again, in our coastal regions, we were picking up a few deaths in individuals for the cause of COVID-19. By April, that picture was changing pretty significantly, and it was no longer, movement along the coast and in areas where we've got big cities and ports and a lot of international travel, but starting to see a lot more infection across the entire United States. And by May, things had picked up pretty significantly across, again, most of the country. If we think about today, just to kind of maybe hone in locally for a minute, we see that when I was putting this talk together on the 7th of November, I was able to pull from our county data the percent positive of COVID-19 cases through November the 6th. And at that point, when you look across the time frame from October the 8th through November the 6th, we were seeing a reasonable percent positivity in terms of number of cases amongst the testing that we were doing. Good amount of testing happening across the county, and between 1% and 3% of all of the tests done were coming back positive, generally speaking. This morning, when I went to pull these data, I can show you that we've gone from 59,656 cases in the last 11 days up to 66,319 cases with a positivity rate. I'll just ask you to indulge me in looking at November 14th, where you'll see we were as high as 9% positivity rate. A positivity rate we have not seen since the beginning of the pandemic. Another metric that we, or other metrics that we can look at to understand, what are the learnings here over time with this pandemic, is the case rate, the number of outbreaks that we're having in the community, whether or not we're seeing upticks in COVID-like syndromic cases. Do we have a lot of influenza? This is, we've approached flu season. Are our hospitals faring okay? Do they have capacity? Are we seeing an increase in hospitalizations? Do our ICUs have capacity? And what is it? And do we have ventilators if people need it? Do we have protective equipment? What's the testing positivity rate? Gives us a sense of, are we doing enough screening and are we picking up the cases when we screen? If we find positive results, are people able to get information, to be called, to understand how and what they should be doing to manage through that positive infection, and how our most vulnerable populations, like our unsheltered or homeless, faring through this? So on the 7th, again, when I was putting the lecture together, things didn't look good. The case rate for the county was at 7.4 per 100,000 population. We had about 33 outbreaks on that day. Our hospitalizations were increasing. We don't like to see any more than about a 10% increase over the past 3 days, and we were up at about 18%. But some of the other metrics that are tracked daily were looking okay. To this morning, when I pull the numbers for you, we have a case rate that is at 10.7 per 100,000. We've shifted from a tier that is used to characterize how well a region is doing, where we might say that there's some spread, to now having significant widespread COVID-19. We have 47 community outbreaks. I think the only number I've seen higher is 49. And fortunately, we are thinking about this from a public health perspective in a way that will allow us to not put undue burden on our hospital system and on the care that people can receive in the hospital. And these are now actions that are informed by what we did in the early time of the pandemic. I don't think it will come as a surprise to you, given the coverage on this, that the burden of SARS-CoV-2 has not been borne uniformly across the residents of our county. We have, as you'll see here, when you look at the rate per 100,000 by racial ethnic groups, a real disproportionate impact in communities of color. The absolute counts are higher, and the rate per thousand is also quite significant. If you look at our adjustments here for African American, Hispanic, Latino, Asian American, Native Hawaiian, Pacific Islander, and American Indian, Alaska Native communities, you'll see that the conclusion that one would draw is different than if they just looked at the count within those populations. And our communities of color are experiencing this at a higher rate than other communities. So back when I initially pulled the data on the 7th, we saw that the percentages, the rates were out of order, meaning disproportionate, and we continue to see that same pattern when we look at that today. If we think about the fact that infections usually lead to hospitalizations, and hospitalizations are an early window into what we might see around mortality, it's important to keep our eye on not just the counts and not just the case rates, but also what's going on with hospitalizations across the county. And here I show by race ethnicity. It's tracking that the disproportionate impact of what we're seeing in the case rates is also showing up in hospitalizations. We'd had about 4,028 hospitalizations through the 7th, and that number is growing in the last 17 days up to 4,236, with our communities from the South Bay, Hispanic, Latino, still leading in the rate of hospitalization. With regards to deaths, we have a similar story, and There were 908 deaths in all of San Diego on the 7th. I pulled the numbers again this morning. I was just going to take the slides out and replace them, but I thought it's really important to see over such a short period of time the rate of increase, and share this with you because it underscores the importance of public health measures to try and help us mitigate through this really important time. So what's going on here? What are we learning from SARS-CoV-2 and from COVID-19? Well, I mean, we're learning that some of the very things that we saw playing out in our chronic conditions across our country, across this region, are also playing out in SARS-CoV-2. And if we look at what's important in determining one's health, it's really a set of upstream social factors. This is a complex interplay between the biological, between the behavioral, and the social. Clinical care matters. People getting access to care and quality of that care is very important. In terms of this health rankings model, we see that the behaviors one indulges in, whether you use tobacco, how your diet and exercise regimens are playing out, your use of alcohol and drugs, sexual activity, sleep activity, those things also matter. The physical environment around us matter, our air and water quality, housing and transit. And there's a large contribution of social and economic factors. So, you know, what's the education opportunity or status? Are people employed? What is the income or the socioeconomic status? Whether or not there's family and social support and community safety. And in COVID-19, we really started to see some of these things bear out, where the racial ethnic differences continued to display many of the patterns that we see in racial ethnic differences for other health conditions. Where in public health, you know, we've acknowledged for a long time that those things aren't just about one's, one's identification into those racial ethnic groups. It's really representing something structural and something systemic that impacts individuals in those classifications disproportionately. And in COVID-19, we see that in addition to all of those other social and economic factors that I just mentioned, we overlay those same population data with levels of food insecurity, with domestic violence, housing instability, overcrowding, unemployment, whether or not there are more essential workers in these racial ethnic groups. Do people rely on public transit? Are they having access to testing and care? So all of this coming together is showing us through this pandemic time how important it is for us to go back and really, first of all, assess some of these upstream social factors as we think about our clinical and public health efforts, and to put efforts into adjusting these social factors if we're really going to get at root causes of disease. I also want to show you something else about SARS-CoV-2 and COVID-19 that has been important for me to reflect on as a public health practitioner. So if we think back to the early days of the pandemic, so I'm dating this calendar back to February 7th. And it turns out here at UC San Diego, we admitted on February 5th, the first patient to UCSD Health who came from Wuhan. And at that point, our campus's experience with caring for COVID-19 began. So we're now 287 days into our campus's relationship with this pandemic. At the time, it was an epidemic. Since then, it got changed to pandemic status. And we had a pretty aggressive approach in the beginning. And it was not just a local decision. This was about taking a state look to try and prevent a national and even further global disaster with the pandemic. So what happened was on March 19th, the California's stay-at-home order went into effect. Governor Newsom said, we are going to stop activities that are typical for all of us. And you can see as you march on along into mid-April and mid-June that things seem to be, in terms of what's on the x-axis there, which is our COVID-19 cases per week for San Diego residents, seem to be holding pretty steady. However, in mid-June, we reopened gyms. We allowed indoor movie theaters to operate. Our bars opened, the zoo opened, our community swimming pools opened, hotels opened, and you can see what happened with our COVID-19 cases per week shortly thereafter. And then look at what happened when we put a public health order that adjusted some of the things that we opened to the cases per week. So we can see how important public health measures are. And the reason that they're put into place is, not to just get the infections and the number of cases per week down, but it's also the impending impact on the hospital, our healthcare workers, and their ability to care for those who need it most, and on the impact on mortality. Another perspective on this that really was impressive to me as I was reflecting on what we've learned in this pandemic is that our social distancing interventions, I like to prefer to call this the physical distancing, because we really want to stay socially connected, but we want to be physically distant. They've really substantially reduced how many people get infected when there's an infection, a new infection in San Diego. So before we put a physical distancing guideline, public health guidance into place, the number of people that were being infected per new infection was about 5. And it varied by setting, but it was pretty consistent with what was going on in other parts of the world as well. With our physical distancing interventions, we were able to get that down to less than 1. So I know people are often trying to figure out what's important in the middle of all of this. And one might argue that what's important are some of the things that we see have this kind of dramatic effect on the amount of people that are likely to get infected. This to me is just another very powerful public health message. So here I'm showing the COVID-19 deaths that were prevented in San Diego County with physical distancing, and again, the early time of observation. So we went from in early March being under no public health guidance, to having a shelter in place guidance, to having things around us that were not deemed essential actions or industries closed. And we can see through modeling by my colleague Natasha Martin and her lab that with no intervention, we would have experienced between 60 to 100 deaths and over 18,000 deaths. And instead, in San Diego, we had observed 128 deaths. So it just reminds me of, one of the primary objectives of a Public Health 101 course on day 1 is to impart upon learners around public health that prevention is so powerful. And when public health is working well, it's about the things that you avert. And it's really a nuanced message to try to communicate to audiences, because you find that people don't see any action, right? When things are working well around us, you don't have a clue who the public health officer is for San Diego. Right now, if I were to ask all of you, who's our chief public health officer in San Diego, you'd probably all be able to say Dr. Wilma Wooten, right? We see her doing public health briefings all the time. So important concept. Instead of mitigating and trying to control outbreaks, what we're really trying to do with our public health guidance is to avert those, 12,000 deaths that we would have otherwise. Okay, so I want to give us a lot of time to talk. And so I just want to quickly sum up with a couple of things about what's on the horizon. Well, I showed you this, this slide before because in the midst of everything that we've had to adjust to around this pandemic, there's still so much going on around us, right? We had wildfires burning. We had to really think about migration and people getting from various parts of our world across our border into the US and the care that was needed. And by care, I mean human care as well as clinical care. Also thinking about, much of the brain health and depression and mental illness that still is an important focus for our public health communities, and trying to robustly inform through a public health lens how we think about behavioral health across our region as well as across our country. And, as always, we're hoping that wireless and mobile technologies will be complementary to some of the things that we're able to do and help advance public health concerns. More specifically, if we think more proximally over the next 12 to 18 months, in addition to not losing sight of all of the things I just mentioned that are chronic and continue to need public health resources and attention, we're all thinking about education in this country. How do we live alongside this virus effectively so that our K through 12 education, our higher educational institutions are able to function with minimal risk. We're thinking about industry and how to keep the economics of our neighborhoods, of our state, of our nation from going into a major depressive state. There's a vaccine on the horizon. Beautiful news over the last 2 weeks about the potential for a Pfizer vaccine, for a Moderna vaccine. And so with that will come the challenges of wide-scale distribution, adherence, and that's going to be of public health focus over the coming months. And then we see, racism as a public health crisis, where a lot of the disproportionate impact that COVID-19 is having is just a master class in what we've been seeing for other chronic conditions over the last 2 or 3 decades. So with that said, I'm going to thank you for indulging me over the last 40 minutes or so and open up for questions.
Thank you so very much, Dean Anderson. That was terrific. And we're very grateful for that wonderful presentation. So Suzanne, would you like to take over the moderating responsibility for the Q&A?
Certainly. So everybody is still muted. You are welcome to raise your hand electronically, and then we will call on you. And when we call on you, don't forget to unmute yourself. Okay, so we have a first question from Dr. Robert Knox. Go ahead, Bob.
Thank you very much for that presentation, very informative. As you know, there's been a certain amount of head-butting between various entities that say that they should remain open, that they're no worse, maybe better at controlling the virus than other entities that are still open. I'm thinking of gyms and churches and restaurants and bars and all of that. Are there any lessons further to be learned about the graininess, if you will, of what gets closed and what doesn't?
Yeah, so, one of the things that we've had to do, and that I've observed happening from a public health perspective is, really going in with a shovel versus a scalpel, right? In trying to figure out how to make that next move when things begin to get out of the range that we can try to manage. Because essentially, it's this delicate dance, Bob, that we're in, where we want to open just enough so that we can manage. And if infections start to go up, we're able to find them quickly, snuff them out before outbreaks begin to occur. So ideally, what we want to have is a situation where we can monitor and attribute to various entities, where the problems might be. And our county does that, and it does that pretty well. However, when you've seen the large public health response, meaning, sort of that big shovel approach versus the scalpel approach, it's when the people who are infected are reporting back, I have no idea where I got this virus. So what that means is that community transmission has gone up significantly, and individuals can't pinpoint where the thing came from. So now you have to really, instead of saying, okay, I can tell that people are getting it when they go to the gym, let's, take a targeted approach toward gyms. Or I can tell that people are getting it when they are in bars, which that did happen at one point in our region. The bars were closed, but not restaurants, right? And so that is where the challenge occurs, is that if it were as easy as having people be able to come back and say, this is where I picked up, or likely where I picked up the virus, then it'd be much easier to do that targeting.
Other questions, members? Bob, you have a follow-on question, or your hand's just still up? No.
I didn't hear anybody else jumping in, so I thought I'd hog the floor. Do we, one thing that impresses me about all of this is the fantastic speed with which A, the virus has done its thing, but B, the response, at least in terms of developing a vaccine. They've both been pretty warp speed, so to speak. Do we learn any lessons for the next time something jumps from a pangolin to a human being about being a little more spring-loaded, either on the vaccination side or on the treatment side or whatever? Maybe the public health measures side as well. I just don't know if there are, getting ahead of it in advance, lessons to be learned from what we're going through now.
That is such, thank you for that question. There are so many parts to the question that you've just asked. One thing is, what do we monitor on a day-to-day basis to make sure that we stay one step ahead? I like the way, you framed that. So there's that, right? How do we stay one step ahead? And then there's this issue of, okay, we are just about there. In lightning speed, we have the potential for 2 vaccines to be on the market. Will we have all of the supplies that we need for the wide scale distribution and uptake of these vaccines, keeping in mind that both of them require 2 doses, right? So now we've got a supply issue, and we're thinking about a human behavior and human adherence component. And then, will this be uniformly, will this have some uniform uptake across the places where we need it the most? And there are trust issues that need to get dealt with that have led to some of the disproportionate outcomes that we see already. And so there are, in your question, some very difficult things and some reasons for hope. So I'm hopeful that the days when I used to get up and think about UC San Diego and say to myself, people are asking me all kinds of questions. It's April 15th, and this is a 4-month-old virus, right? Are so better informed now when I, stand in front of audiences and I say, okay, this is an 11-month-old virus. We know a lot more than we did back then, but the learning hasn't stopped. So you talked about, the next time it jumps from a pangolin to a human, you probably heard recently about minks getting infected by humans, bringing the infection back into humans, and then the entire mink population in Denmark has to be culled, right? And so we're taking, steps forward, getting a few steps backward, and so much of it sits in the space of, okay, we get it. We're going to have reductions in mortality because we understand how to treat people better. The therapeutics are better. But at the same time, we don't quite yet have the adherence that we need on the public health side. The wearing of the mask would actually likely reduce the infection transmission, the inadvertent infection transmission, because I think people don't really believe that they're just out there being careless. They don't know they have the infection often. And because there's no, they're not wearing the mask, they inadvertently give the infection to others. So we know a lot, but we need the behaviors to follow the knowledge. And then, with the therapies, they're here, but we're also going to have this really big effort to getting them to the communities that are needed. And we have to keep that supply chain there and robust.
Roger Sprague?
There, am I unmuted?
Yes.
I'll preface this by saying that I am a confirmed mask wearer, but I think we're going to be hearing a lot about a study from Denmark that just came out in the Annals of Internal Medicine that questions the value of masks. And I wonder if you could comment on that.
Well, I haven't seen this study that is likely to come out soon in Annals. And I will say that from what we have here in the US, we see that the reduction in transmission that happens when both parties or all parties engaged in an exchange are masked is significantly higher than when one of the two or parties are masked, and significantly lower than when no one is masked. And then this is related to also whether or not you're indoor, whether or not you're outdoor. If you're indoor, what is the air ventilation and cleaning procedures that are at play? If you're outdoor, are you downwind from someone who's infectious? How far apart you are from each other? If you're outdoor, even being outside alone doesn't reduce the risk as much. So there's so many variables involved. But if you were to ask me my assessment of the literature, I would say the two best things that one might do for oneself is to put on a mask because it protects your portals of entry and exit, and to remain physically distant, because even if, let's say, your face covering is a gaiter and it's not a surgical mask like the one that I might wear when I leave my house, and you have someone sneeze toward you or you sneeze toward them, the farther apart you are, the less likely for that aerosol transmission to happen. So I will look out for that article, Roger, but it would certainly be a paradigm shift if it had something in it that could undo what I've seen thus far in the literature.
Great, thank you. And I think it just came out, so I apologize for
that's
throwing
okay.
something
I'll look
from
for
left
it.
field.
It's always important to
Thank you.
learn something when you come and do a lecture as well. So I thank you for that.
Thanks very much.
You bet. So So I see two things in the chat. One's from Karen Heskett. Participants were randomized into the mask group or the control group, and those in the mask group were given a supply of surgical masks. All participants completed weekly surveys and antibody tests with PCR testing if COVID-19 symptoms developed, and at 1 month. At the conclusion of the trial, infection rates were similar between the two groups. Then Bonnie Kaiser writes, a number of epidemiologists have raised concerns with the design of the masking study that was mentioned, especially the first thing I thought, Bonnie, as I was reading through Karen's note, especially adherence to mask wearing. So we have to make sure in any intervention, there's intervention fidelity. And so we need to understand that, which is what Bonnie is raising here. And until we understand the level of adherence to the intervention that they asked people to execute, we would have some questions about the conclusions drawn by that study.
I have a question, but I don't know how to raise my hand.
Oh, go ahead, Rachel.
Okay, thanks. What have we learned from this so far in terms of messaging, in terms of getting people to trust public health officials and comply with recommendations such as mask wearing, and understand the nuances and why we make recommendations sometimes even if the knowledge isn't 100% there yet?
Yeah, yeah, that's so, yeah, thank you for that question, Rachel. So needless to say, although you see at the top of my screen what I've come up with as a message that I, try to share with everyone, together we can do this, together we can stop the spread. There has really not been locally across this state or across this nation a coordinated public health campaign. There isn't, none of us can repeat out what is the, campaign, what's the slogan that's going to get us through this pandemic. There hasn't really been one. There have been lots of different things going on, but there's not been a real coordinated, highly coordinated effort. So we've learned that in the absence of that, here we are, right? We're headed into, for all intents and purposes, if we are looking at Europe, looking at our own country, looking at our own local numbers, we're in the midst of a surge, another surge, right? And this time we're seeing numbers that far exceed anything that we've seen thus far during the pandemic. How do we think about, getting compliance? Well, I think that requires trust, as you hinted at in your question. And I look at, if you look at this state, can anybody, well, maybe this Zoom is not the right format for this. If we were together in person, I would ask the question, where in our state have we had really great success in a metropolitan area around, COVID-19? San Francisco. San Francisco's been in the yellow tier, San Francisco County, yellow tier. What's going on up there? Like, how can they get in the yellow tier and we can't? I can't tell you for sure. So I don't know how many of you know who Eminem is. Do you know who Eminem is, the rapper?
Mm-hmm.
Okay, so he has this great line to one of his songs, and the opening is, I can't tell you what it really is, but I can tell you what it feels like, right? And so I don't know what's actually going on, but I can tell you what I, feel might be going on. I think the HIV/AIDS epidemic created a level of trust and rigor in communication and ability to connect with the community in the San Francisco area that we have not been successful, or many other regions have not been successful in doing with their local constituents. And so maybe that's what's going on, right? The health department there just kind of knows how to message around things, and maybe the compliance follow-up isn't what we think of as, sticks. Maybe they're carrots involved. Like I don't know, but I know it's happening in some places, and so it's possible. So the learning here is we need a coordinated strategy, which is Public Health 101. I teach this basic class, and all of these things I tell the students, we haven't been living through it, but now I see it all just, play out so beautifully, highly coordinated, and it has to be local, state, and national. And then you've got to have a way to ensure that whatever policies you enact actually have some teeth behind them, right? And we haven't really been doing that either. We told people that we were under a shelter in place. As soon as some things became open, they were supposed to go out and be masked. And you saw it. I mean, no one had a mask on in this beautiful town of ours. It's taken a lot of devastation to get people to actually begin to have uptake in some of those public health orders. The other thing I should say, because I see a question coming in the chat about the role of the new graduate school in advising public officials, advisory role in the future of the San Diego region, et cetera. So Ron, this ties really nicely into a dream that I have for our new School of Public Health. And I think we should not let any person graduate from the University of California, San Diego without taking a Public Health 101 class. And I say that because I'm envisioning how we experienced this pandemic from even mid-February, when we were trying to talk to people about how an epidemic was looking like it was going to be a pandemic. People are like, it's just the flu, right? People were not listening. And I think if the baseline public health knowledge and awareness was higher, we would have recognized this sooner as a community. We would have probably listened with a different ear as public health messages were being crafted. And we perhaps would have gotten that basic public health principle that small individual actions, small actions like putting on your mask, even if you cannot see the personal benefit, will often translate into significant public health benefit. And it's hard to make those connections if you've never heard these concepts before. So I think people, our school should take that on as a mission and make sure that we have an informed citizenry, because I think Rob asked this earlier, it's not the last time that we're going to face another highly infectious virus being running rampant in our society. It's going to be how we manage through it. You noticed with MERS and some of the other infections in Asia, their compliance with some basic public health things prevented those epidemics from turning into pandemics.
We have a question from Kirk Gardner. Kirk, go ahead, please.
Thank you, Susan. Thank you, Dr. Anderson. Over the weekend, the New York Times ran an article on the front page lauding capitalism, its successes, and its areas of failure. And it mentioned pharmacy and could have included in that almost all of health systems. You had noted in San Francisco the success they'd had with AIDS up there. And the Times noted that, in fact, if you want to deal with the failures of capitalism, you really have to be prepared to act politically. And that works from the grassroots level up. Is public health prepared to respond at the level necessary for meaningful political activity?
Yeah, great question. So in some camps, they'll say health is apolitical, right? Like health is health. We know that to not bear out in our realities that way. Public health is that discipline that really lives at the intersection of science, clinical care, and social justice. And there is no way to address social justice issues if you are, to address them effectively anyway, if you're not prepared to deal with policy, politics, and the various things that come with it. So I can't speak for the entire field of public health because it does operate differently in different regions, in different schools, et cetera. But I will tell you that if you look across the top performing schools of public health, and if you look across the top performing health departments, public health departments in this country, you will see that they do get quite engaged in the political zones of those regions, because, you know, ultimately the policies that we put into place, as I showed you, you know, in some of the diagrams in the talk, they matter for outcomes for health. And if we pretend that they don't, we're kidding ourselves, and we're not going to get anything done.
Well, I think we could go on for quite some time with interesting questions and very insightful answers, but the time, I think, has drawn to a close, because we need to let Dr. Anderson get on to important things and everybody else to do the same. And I would like to thank you very much, Dr. Anderson, for your presence today, for your clear passion and wisdom and insight into the challenges that we're facing and will be facing. So please accept my sincere appreciation and gratitude on behalf of all of us here and those who will be watching this presentation later on recording. I would like to thank everybody for their time today. A reminder that our next lecture will be on January 13th. We skipped December because of the holiday. And Professor Kathy Geer from the Department of History will be lecturing on property, psychology, and the environment in a warming world. So we go from crisis to crisis. And again, Dean Anderson, thank you so much. I would also like to remind everybody that on December 12th, Saturday, December 12th at 12 noon, so as Susanna's pointed out, 12/12 at 12, our joint Emeriti and Retirement Association holiday party will be held right here in your living room or wherever you are. And we have a nationally known comic, Moody McCarthy, who will be sharing his yucks with us. So I hope you can all make it. And again, Dr. Anderson, thank you. Everyone, have a great holiday. Be safe, wear your masks, and we'll see you at the holiday party. Take care and thank you.
You're welcome. Thank you for having me.
Thanks so much.